When I was writing my book on manipulation, I was doing research into the various catastrophes that had occurred, especially in the cervical spine, but also in the thoracic spine, lumbar spine. And whenever you look into those, a group of tragedies, and you study the technique, that was tough finding out, okay, what technique did they do? And I came across an article from 1970 in which the chiropractic insurance company, hard to imagine a profession with its own insurance company, but they do, turned around and said the incidence of stroke and death from rotational manipulation is so high that if we find that you have performed a rotational manipulation, you will not be covered by malpractice insurance. And I'm thinking, now there's a statement. So the culprit was obviously a rotation. That's where 90% of the tragedies were actually occurring. And one of the worst culprits still being performed today is where we take the patient's head, we side bend it, and then rotate it till we get an end field, and then back. And if you see certain practitioners, they will use the same technique for different levels. Like, but that's good for C2-3, but that's good for C5-6, and I'm looking, thinking, it's the same technique. That's the worst culprit of all. And the reason is, and this work was originally done by Olaf Evaniet, who was my teacher from the Norwegian system. And he pointed out that when we side bend to the left, everything from C2-3 down is rotating left. But when we look at the craniovertebral joints with left side bending, it's rotating right. So the two rotations are opposite to each other. And the structure that's going to take the hit is the vertebral artery. As it goes from C3 to C2, it's going to be overstretched. And then it kinks as it starts to go through the other two segments. So now you come up, you've got the artery probably on full stretch, and then you manipulate. All of the information done on the vertebral artery suggests that the vertebral artery is an elastic artery, unlike the carotid, which is a muscular artery. And that with extracranial elastic arteries, and they're quite emphatic about pointing that out. This doesn't mean the ones inside the head, it's the ones going up to the head. They can extend about, the figure that they gave was 17.5%, so say 20%, beyond which the artery will fail because of being overstretched and damaging the tunica intima, causing a so-called arterial dissection. If we couple that with some of the latest findings on the onset of arteriosclerosis, things don't look any brighter, they get grimmer. When I came to Canada 50 years ago, I had a friend who was a pathologist at Chicago. She was a forensic pathologist and dealt with doing autopsies on young males from different gangs, getting shot, knifed, different things like that. And in the course of the autopsy, she would send tissues off to be checked. And I was talking to her and she said, oh, I'm flabbergasted. She said, like, when I left Ireland, at the same time you came to Canada, she said, the average age of the onset of atherosclerosis was just under 30 years old. She says, these boys that I'm seeing, the average age is 18. Almost half. And unfortunately, recently I read an article where they're saying, because of our poor dietary habits and the lack of exercise, the lack of play that kids are doing now, the onset of atherosclerosis is as low as 13. So it's quite likely by the time people are reaching their 30s, 40s, 50s, the atherosclerosis could be quite advanced. If we add to that high blood pressure, it's beginning to get quite a volatile mix. So I thought to myself, if we're going to make a safe system, is there any such thing as a perfectly safe system? Probably not. Because there are things we can't measure. There's a substance called cytohistine, which some people have excessive amounts of, and that tends to lead to more fragile arteries. We would never know that. They may not have even never been tested for it. So I thought, so how do we make things optimally safe? And I thought, well, the one thing we are definitely going to avoid is rotation. If the chiropractors are saying we shouldn't be rotating, that's enough for me. And certainly when you look at the literature, that's the main killer. But then I had another epiphany. I thought to myself, if we can make a joint move in a manipulation in exactly the same way it moves in real life, how much danger can there be? Right? They've been walking around, they've been turning, driving. So if I could do the same movements that they're doing every minute of the day, then that would be the optimally safe technique. So apart from manipulation, apart from the number one rule, which is find who not to manipulate, that's at the top of the list. That's all your contraindications. And the next thing is, when you manipulate, make sure it's as close to nature as possible. So the first thing I'm starting to investigate is the craniovertebral joints. So I start looking at the literature, and I notice there's very little agreement on the way these things move. There was one study done from Japan, for example, where they had this young guy seated in a swivel stool. They had his head going up to a fixating apparatus, and his head was in a helmet. Because one of the main problems when we're looking at movements and x-raying them is this shift. When you do this, everything shifts to the opposite side. Well, the camera has to now refocus, but now you've got a different starting point. So it blurs everything. So they thought, okay, we'll be clever, we'll put his head in a helmet, fix it, and then rotate him from underneath. That way we don't have to rotate the head. And they came up with the conclusion that when you rotate your head to the right, the atlanto-occipital joint relatively rotates left. And I remember looking at that and thinking, okay, what am I missing? That doesn't sound right at all. But they showed when you rotate your head to the right, in that circumstance, the atlas moved so far, faster than the occipital, that at the atlanto-occipital joint, relatively, there was left rotation, with right rotation of the head, supposedly. So whenever you find something that doesn't make sense from the research, the first thing you check is the construction validity. In other words, how is this put together? Of course, when you analyze it, it suddenly hits you. You've got his head fixed, and you're rotating it from below. But what happens when you rotate the spine? What happens to the length of the spine? You get an S-curve, right? Which means it's shortening. A straight line would be the longest distance between 2 points. As soon as you put a curve in it, now you've got the shortest. So what were they adding into the mix inadvertently as they rotated from below? Traction. And I remember thinking, well, it's a shame that it's messed up, but it does explain why traction with rotation is amongst the major killers in manipulation. A combination of those two forces is a very unhappy result. And there were studies that would say when you rotate your head to the right, the AO joint side bends left. And I'm thinking, well, I don't see it side bending left. But when I rotate my head, my eyes stay level. The whole purpose of that is keeping those three major balance mechanisms in the same plane. So in the end, frustratedly, I thought the only way I'm going to find the answer is to feel it myself. Can't rely on radiographs, scans. They all seem to come up with different ideas. And I thought, is my palpation going to be accurate enough to come to a correct conclusion? And there's a couple of events. One was working with an orthopedic surgeon, and I was treating one of his patients, and he had a fixated C23, and we manipulated it with great success. And I said to the surgeon, so how come you can't see that on an X-ray? He said, oh, the answer to that is simply your palpatory skills are years ahead of visual technology. Because with visual technology, you can't feel anything. So you have to rely on it being optically accurate. And it's not. So then, the next one was the article by, can you remember that name? The guy who, I think the title was, Why do you think we can't feel movement?
Oh, sports physio. I'll find it.
Yeah. And it was really good because it's explaining the neurology of our fingertips and how there are different types, I think 4 different types of nerve ending. We've got ones that are stereognosis or shape, we've got ones that feel pressure, heat, and movement. And it's explaining how your fingertips are something like 5 times more sensitive than the palm of your hand, which is several times more sensitive than your arm. So as you go more distally, the innervation becomes much, much more significant. And he's asking the question, who would doubt we can't feel movement? It might only be 1 millimeter or 2 millimeters, but it's enough for your fingertips to pick up. So I'm going to take you through a challenge, the same way I've done with several groups, to see what conclusions you can come up with. Because my point is this, if you can feel it, you can fix it. But you've got to know what movement it is that you're trying to regain. So I'm going to ask you to do certain things, very simple things, nothing complicated, and then we'll see if we can put that together. Because I can tell you now, it's not going to agree with what we read in the literature currently. So you've got to be confident enough in your own palpatory skills to say, it doesn't matter what they say, this is what I'm feeling, and what I'm feeling is going to treat the patient. That's the important thing, not what I read in an article. So the first thing is you're going to have your model or your partner in sitting, and you're going to rotate the head to the right, at the same time palpate C1 transverse process. And I'll demonstrate that.
Hold up.
No, that'll be okay. Well, first thing is, can you find the transverse process? The transverse process is variable, but it's going to be somewhere between the angle of the mandible and the mastoid process. And even if you can't feel it distinctly, you know your finger's in the middle of that gap, you're over the transverse process. So now we're going to keep her eyes level and rotate. First one way, then the other. And what I'm going to ask you to do is get rid of any previous concepts you might have and try and sense the most obvious movement, because the most obvious movement is going to be the largest movement. And we're also going to be looking at this side bending. Like people have said, well, no, when you rotate your head to the right, it's not like you side bend to the left in the occiput, but C1 side bends. Okay, then I should feel that, right? As it's moving, I should be able to feel that tilt by judging what's happening between the 2 transverse processes. Take them through the entire range of motion, because yes, the top 2 joints are responsible for 70% of the movement, but that doesn't occur at the beginning. It occurs throughout the entire range of motion.
Visit us at aspireomt.com.